uh, I wanted to get more time on hands-on experience. So why do we need anticoagulation? It's obvious. So when the lead comes in contact with a non-endothelial surface like a plastic tubing which you use for the ECMO circuit, so coagulation cascade gets activated and it clots off. To maintain the patency of the circuit and to run the circuit, we need some form of anticoagulation so that we can run the circuit without much problem. And it's like one of the most important aspects of the extracorporeal circulation. At the same time, if you're not careful enough, that can cause a lot of problems as well. And the commonest problems on ECMO is related to either over anticoagulate or under anticoagulate. But before we go to what we use, what kind of anticoagulation we would need for run ECMO? We need anticoagulant which can inhibit coagulation cascade and platelets within the ECMO circuit, but not in the patient. So only in the circuit, not in the patient, so that when the patient doesn't have any bleeding complications, and we're easy to titrate for what are the clinical effect we're desiring, and it should be easy to monitor. And if there's a problem, we should antagonize easily so that we can reverse the effect, and it should be inexpensive as well. But like many ideal things in the world, it doesn't exist. But what we use close wide experience is unfractionated heparin, which is used by default all over the world. There's some other anticoagulants which we'll come to later, but by default, all the ECMO centers, they use unfractionated heparin. Then we'll talk about how the heparin works and how to titrate this and see. Okay, so the heparin is basically works with potentiation of antithrombin activity. It doesn't in itself inhibit the coagulation system. Antithrombin 3 is synthesized in the liver, which we will all have in the circulation, and it helps to maintain the homeostasis. And the heparin, when you give heparin, that increases the activity of antithrombin 3, which again in turn inhibits the thrombin action. So that's how it works. So somebody has antithrombin 3 deficiency or a liver problem, and the heparin doesn't work very well. And that is well known in especially neonates and children who have physiologically low antithrombin 3 levels. So in those population, we need slightly higher heparin requirements. So this antithrombin 3 heparin antithrombin complex mainly works inhibiting the thrombin form action, and it also works on the factor Xa. It also has another side effects in the coagulation cascade. Main effects would be the thrombin and factor Xa. So heparin doesn't work if antithrombin levels are low. In the Western centers and high volume centers, they usually measure antithrombin, and if it is low, they tend to give antithrombin concentrate, which is, we don't have facilities in India. But what somebody, if you think heparin requirement is going up, then it's sufficiency of antithrombin. But what we need is large quantities to replace that. Again, how much heparin we need? There's no evidence for that, how much heparin you need, but whatever you need to maintain the circuit patency. And you need to take into consideration the patient coagulation system. Is the patient bleeding, or is patient hypercoagulable state, or how is the patient coagulation system? So you need to take this account as well. And each center has its own guidelines, and you have to adjust it. It's a dynamic thing. So you can't have one fixed heparin dose for all throughout the circuit time. So depending on patient coagulation system and the requirement, and then you adjust the doses. What does ELSO gives? It has some guidelines. So when the patient goes on ECMO, you'll give 50 to 100 units per kilo at the time of cannulation. Again, whenever the patient comes to you, first assess his coagulation system. Measure PT, APTT, APTT, and then see So start with 50 to 100 units per kilo, the cannulation, and then you need to and then try to maintain the ACT, which will come to ACT is one way of monitoring the heparin effect. So we'll come to that what it is. And we try to maintain the ACT around 180 to 200. Again, if the patient is bleeding, we'll try to maintain slightly lower ACTs. So if patient is hypercoagulable, then trying to maintain slightly higher ACTs. And somebody is a more increased urine output, like patient is on furosemide infusion, and because the heparin gets excreted in the urine, so you might need more dose. Or if somebody is going to platelet infusion, so that inactivates the heparin action, so you might need more heparin. Take those into consideration. So how do we monitor? So the different ways of monitor, the activated clotting time, APTT or Antifactor Xa or thromboelastogram. So we'll go one by one each. So activated clotting time. It's a point of care testing done at the bedside or with the whole body mixed with activator. This generally is a perfusionist or the cardiac surgeons, they're well aware of this thing. They do it for the cardiac surgery. Thing which can be done. Where cardiac usually tend to maintain around 300 to 400. For ECMO, we tend to maintain around 180 to 200. Advantage with this is the bedside and immediate test. You can do it and you can adjust the doses. So the disadvantage is it doesn't correlate very well with the heparin requirement. It does give some idea, but it doesn't correlate always with a heparin requirement. So some centers, what they do is, if say ACTs come up to 200 or 300, even though it's a very high ACT, they don't come down less than 10 units per kilo per hour if there is no bleeding for the patient. If the patient is bleeding, then that's a different issue. If the patient is not bleeding, and even the ACT is high, and then rather than stopping heparin altogether, they don't come down less than 10 units, sometimes 8 units. Similarly, they don't go more than 30 to 40 units per kilo per hour heparin if the ACTs are low. So the other way to measure is APTT. We all aware how the APTT is done, but the disadvantage with it is you have to send it to the lab and maybe wait for at least in the lab is within your same hospital. You can get it probably at least it takes a couple of hours, not more, less than that. Sometimes it takes more than that actually. So that's a disadvantage. We can't do it at the bedside, but there are some kits available which can be done at the bedside, but that's not been widely used. So when you're looking at the APTT, aim for 1.5 times to 2.5 times the normal. Again, it's not a very good correlation with heparin activity. And if you're trying to correlate ACT and APTT, it doesn't correlate always. Other one is the Antifactor Xa. So what it is basically, when we talked about the action of heparin, one of the action heparin does is it inhibits the factor Xa. So when you're measuring the Antifactor Xa is, you take a blood sample and measure the water, the leftover factor Xa by using the Antifactor Xa. So that gives us some idea of heparin activity. So it seems to correlate better with the heparin activity compared to the ACT or APTT. But the problem with it is expensive, it's not available in India. Maybe in future we may get there. Some of the Western US centers are using routinely Antifactor Xa instead of ACT. But again, it has its own issues with it. The other things can be used is thromboelastogram. It's a whole body, whole blood testing, point of care testing, and it gives information of integrity of coagulation cascade and how the platelets are functioning, and the platelets and fibrin are interacting, and how the clot is lysing. And it's quite useful when the patient is bleeding. Again, it's not routinely available. But the way to do it is, I think on Thursday there's an entire session on thromboelastogram which can be explained in detail, but give a brief idea. So you take a blood sample and put a small steel rod into it, and that rod try to rotate into the blood, and the way it rotates, the force required to rotate, it changes as the clot is forming, and then clot is lysing. So the force is required to rotate the rod is depicted in a graphical representation, and that gives an idea how the coagulation is initiating, how it's maintaining, and how the clot is lysed. So depending on this is the kind of graph you get it, and depending on the way. This is how the normal graph looks, and depending on the various measurements you can make, and depending on which point is not normal, and you come to conclusion whether it's a coagulation factors deficiency or the platelet factor deficiency, or is it a heparin over heparin is a problem. So you can determine on that. But it's quite useful. Generally, the patient is bleeding. Somebody, like you try to adjust the patient bleeding on ECMO, you try to correct the coagulation and stop the heparin. If the patient is still bleeding, then you don't know what to do. Then you do these things and they'll give idea what to supplement. But none of these tests are gold standard. And the ACT is the widely used, and as everybody has most experience in that. But if you're in a doubt, use a combination of tests. Don't just go by the test and adjust your heparin. Look at the patient as well and circuit. So there are already some clots in the oxygenator in the circuit, and if this patient is not bleeding and ACT is giving low, or if ACT is giving high or anything, maybe you need to take all this in consideration before you change the heparin dose. So to decrease the heparin issues, some people came up with the idea of heparin bonded circuit, as Sunil mentioned. If you have heparin bonded circuit, then the heparin requirement comes down, especially the patient has a bleeding after a surgery. But it affects usually lasts for a few hours. Sometimes it may, as Sunil said, sometimes there are instances where we run the circuit without heparin for a few days as well. So the heparin gets released slowly into the circulation, so the heparin requirements are less. But the problem with heparin is, again, it needs antithrombin for effect, so you need to be aware of that, and it's difficult to monitor. And heparin-induced thrombocytopenia is more of a problem heard about in adults, but I've not seen as such myself, but pediatrics is very rare, heparin-induced thrombocytopenia. And in our settings, mostly it's probably the sepsis which is causing thrombocytopenia rather than heparin itself. So because the problem with heparin and other issues, so there have been other anticoagulants have been in research and some of them in practice as well. Important ones as direct thrombin inhibitors. There are three types of there: argatrobat, bivalirudin and lepiridin. So what it does is directly inhibit the thrombin effect, so antithrombin levels for that, and it seems to be titrated better than heparin in some studies, but again experience is limited and it's not available in India. But I remember that Pranay used bivalirudin once, I think, in one patient. So that may come up in the future when the more research and more studies are done. And there's some other in pipeline in research where the direct factor Xa inhibitors and the factor 12A inhibitors, they're still a research thing. And other idea is nitric oxide releasing circuit. So this idea came basically because in circulation, the blood fluidity of the blood is maintained by endothelium, which secretes the nitric oxide, which in turn inhibits a platelet aggregation. So with that idea, people come out with a nitric oxide releasing circuits. So where this polymer is mixed into the circuit when the circuit is being formed, and that releases nitric oxide where blood comes in contact with it. So they are still in the experimental stage, so hopefully that might come in future, so we'll have better idea with that. So to conclude, basically, so anticoagulation is a vital aspect of ECMO, and heparin is a by default anticoagulation, and ACT is widely used to monitor the heparin effect. And titrate the dose as per the patient requirement, not just go by the numbers. And some anticoagulant, novel anticoagulants will be available in future, and we'll discuss maybe in the future those things. Thank you.